So I am delighted to be introducing Baroness Louise Casey. She is known to everybody in this room and known very well for a significant range of things that she has done across government, across many prime ministers, and really, really significant work. And I'm absolutely not going to name them. What I do want to name is what I think we see from Louise in all of her work, which is care and compassion and conviction. And what comes across to me is the experience of somebody who's done real work on the front line, and that experience has never left them. I started my career in street homelessness, and I think there are experiences that you have and keep you going through all of the work that you do. And I see that in the work that Louise does. And I hope that we're going to continue to see it in the work she's doing now. Finally, I was struck and in awe of what she chose to keep in Desert Island Discs. And that was a television and the Marvel movie collection. And I feel that's quite inspiring when we think about the huge task that she has ahead of her as she looks at social care. So, Dame Louise Casey.
Thank you. So I feel slightly, how can I put it, nervous talking to this audience. Partly because this is my first speech on the issue of social care, partly because it's quite a rarefied audience. A friend of mine who works at the Health Foundation said, "Louise, you're talking to health royalty." So if ever I was a tad nervous around the edges, that just made it a lot worse. That's the only joke in the entire speech. Everything else is pretty dry, and I've got the after dinner slot, or after lunch slot, which is actually probably worse than the after dinner slot, so bear with me. And also, I'm not using that. I wish that Chris this morning had said, "Next slide, please." That would have had us all rolling in the aisles, Chris, but anyway, there you go. You didn't. You've now mastered the slide deck, so that was fabulous. That's the second joke. I might go for a third. I don't know, you seem like a nice audience. This could be a bit of fun, but we're live streaming, so it could all go fecking wrong, couldn't it? Right, anyway, so first of all, I wanted to thank Thea and the Nuffield Trust Foundation for having us here today. We deliberately wanted to be with the Trust for a number of reasons. We're going to work together on some international comparators to do with social care, which I think will be really helpful to us. And partly because actually I did want to deliver a speech, and it's a proper old school speech on a piece of paper that I will read at various points, that actually did have a bit of a health direction to it. So bear with me if I enter into some of your world that I'm less familiar in. So since beginning in this role as chair of this independent commission into adult social care, the team and I, many of whom are here today, have met hundreds of people. We've been on countless visits across the country, and actually we've been inundated, I would say, with support, including from many people in the room here today. Thank you so much. And especially to those people with lived experience for their help and their insight as we've been starting and going for the last 12 months. But I think what I want to do today is actually start in 1948, when I hope nobody is here from 1948. I know you doctors are keeping me alive for a lot longer, but even that's ambitious. Fourth joke, I'm doing really well. I want to start in 1948, when Beveridge set out his vision of a post-war Britain, a plan to tackle the 5 giants, the social evils, as they were described then, that Britain was facing. He set out that as a nation we needed education for ignorance, we needed full employment for idleness, we needed housing for squalor, we needed the National Health Service for disease, and we needed a social insurance system for want. He didn't set out what we needed for social care. Why? Because we frankly didn't need it then. Either because we died younger. In 1950, a man's life expectancy was 58. Today, gentlemen, we allow you to live until you are 79. Come on, that's quite, you know. Conditions that we now live with were fatal in 1948. Or, where people did need what we now would call social care, it was provided largely by family because fewer women worked outside the home in their own paid employment. Today, thankfully, 73% of us are employed. And actually, where the family couldn't step in, I would argue that the then newly formed NHS would and could. If we fast forward to 2026, we live longer, a fact we should definitely celebrate. There have been enormous advances in medicine and technology, which also mean we survive with conditions that would previously have killed us. In the past 50 years, the cancer death rate has fallen by more than a fifth. And thank God, when we bring babies into the world, they now survive with conditions that would have been fatal, would have been life-limiting, and led to what we now call a premature death. And I have to say, there's one example close to my heart that it gives me great joy that in 1949, the life expectancy of a person with Downs was around 12, and today, on average, it's around 60. We've made huge progress in women's rights, and there has been progress in disabled people's rights. And those are all facts that we should definitely celebrate. So though a lot has changed since 1948, we're getting older as a nation, things like dementia, therefore, has gone up. People live with multiple conditions, like your diabetes, your heart disease, your cancer. So we're sicker too as we age. And interestingly, more people identify as disabled. A staggering 16.1 million people self-identified as disabled in 2022, of a population that was probably 67 million at that point. And staring us in the face, and we discuss this in plenty of forums and places, is the fact that the number of older people has increased more rapidly than the number of working people. But this means more people to care for, with fewer people to care for them. And we all know the characteristics of our society have fundamentally changed. And I think if Beveridge were alive today, he would have had a sixth giant to tackle: how we support and care for an older, sicker population and greater levels of disability. But though we know all of this, as a nation, I don't think we've looked this fully in the face. We haven't had a moment of what I call reckoning, a stocktake. We haven't had our own Beveridge moment. Instead, we are left with a system which has add-ons and workarounds, sticking plasters and glue, holding together something that is creaking, which is inconsistent and often impenetrable. And you will hear people talk about, including me, this system, but the truth is, I don't think we really have a system. Social care didn't feature in Beveridge's vision of a post-war Britain, and I don't think that vision exists sufficiently now. All of you in this room know that I am not the first person to try and make sense of all of this. And one of the things I have learned in life, as I've now hit the age of 60 plus, is you have to look very, very carefully at the good people that have come before you with some humility. Good people have tried. We had the Blair Royal Commission on Long-Term Care for the Elderly. We've had the Brown White Paper on building a national care service. We had the coalition government's fairer care funding done by Andrew Dilnot. We've had David Cameron's dementia challenge, and we had Theresa May's, albeit short-lived, manifesto commitment that ended up being labelled as the dementia tax. Since 1997, we have pored over and studied at least 22 major reviews, commissions and reports, all attempting to fix the problems with a system that doesn't really exist. Now, I also know, and we need to be really clear about this, that changes have been made and important steps have been taken forward. The community care reforms were powerful, greater personalisation, carers' rights and the 2014 Care Act. But I want, as if I can, just to be a little honest about some of those changes. Yes, we all welcome and we should welcome the Care Act. But too many of you in the room, and I have heard of too many examples of council and others not being able to meet their responsibilities because the money, the infrastructure and the systems are not there. Councils have been hollowed out by years of austerity and funding cuts, forcing them to a position where they gatekeep and often they feel they do the bare minimum. My own view, and I'm afraid I've said this to do with other areas of work, is that it's really poor and irresponsible government to give people new rights without taking any responsibility that they can be fulfilled. For all the reforms, reviews and well-intended legislation, none of it ever really had the full political backing that was needed. Because unlike the NHS, or indeed the benefits system, social care has never had its own creation moment. No moment when the nation decided what it was for, what people should expect, or who should pay and how. Instead, we've inherited a system frankly shaped by a very different age, and people have lived with it without ever having the moment of reckoning that I think we now need. I'm going to focus today just on a few parts of the social care system, not because they're the only things that need fixing, but because I think they reveal so much. But before I do, and particularly to those colleagues and friends who work in the social care sector, who are in the room today or indeed watching, I want to be absolutely very clear that when done well, social care isn't about services or systems. It often is not glamorous. It's about giving someone independence and about showing compassion, about people keeping their quiet dignity. When social care works like that, quietly and humanely, you may not notice it at all, but it matters, and it matters greatly. I think that quietness, though, masks part of the problem, and it takes us straight to accountability. No one owns what people see as a problem, or indeed you could see as an opportunity of social care, yet everyone owns it. National oversight is split. Policy responsibility sits in one department, funding responsibility sits in another. The NHS itself has 6,200 GP practices, 700 hospitals, 200 NHS trusts and 42 integrated care boards. I can't help but just have a little pause on integrated care boards. I assumed that that they would deliver integration for the public, that they'd make the world of GPs, hospitals, district nurses, social workers and carers connect together to provide integrated care. In fact, they're there, I believe, for the system to sort itself out within health. And even that, all of you complain about quite a lot. That's not in the script, it won't be in the speech that's on the website, but it's true. Local government also has 317 differently democratically elected councils. Important, those three words. 153 unitaries and counties that hold responsibility for social care, a further 164 differently elected district councils that hold responsibility for housing. There are 18,000 care providers that operate independently, which is actually 90% of them are run privately for some profit. And all of this is regulated in this emerging world that has been created by the giant that is the CQC. And the truth is those that need help, those at the bottom of that looking up, feel that division every step of the way. They navigate their own way through a myriad of processes that we in the system have cobbled together, with drawn-out discussions on who pays for what, and to many of the public, and indeed I'd say workforce, it is simply anxiety-laden and confusing. And let's be honest, I've been in Whitehall long enough to know, and I've run enough cross-government programmes to know that when responsibility is shared, it can end up being nobody's responsibility and fully accountable for it. It took nearly 60 years after Beveridge for anybody at a senior level to have social care in their job title in the Department of Health. The godfather, as I fondly refer to him, with enormous respect and indeed affection, David Bean, was appointed as the first Director General for Social Care in 2006. And he had a team at that point of just 6 people on social care and obviously massive other health responsibilities alongside. It wasn't until June 2020 that a Director General was able to devote their full time to social care. And just pause for a moment and remember what was happening in June 2020 in the world of what we call social care. So, sorry, got that off my chest. So, despite really good people, I would say social care has remained underpowered. And you can see that underpowering more than in many other areas in the world of adult safeguarding. The very part of the system intended to protect the most vulnerable from harm, abuse and neglect. Instead of a national safeguarding board, serious safeguarding failures are addressed as isolated local problems. The same serious failures are identified again and again in different areas of the country, but with no subsequent national scrutiny, national action, or national consequences. There's no requirement for serious cases to be escalated to a formal national system to share lessons learnt, that's a tough one, or spot themes. Colleagues, esteemed colleagues, tell me that it feels like a voluntary effort, entirely reliant on organisations, thank God for them, like ADAS and others in the sector to create their own approach. Now, some might call this localism. I call it an abdication of responsibility to protect people who are vulnerable or at risk of abuse. We don't allow it for children. I don't understand why we're allowing it for vulnerable adults. A word that is used again and again when people talk to us about social care is fragility. Let's start with the staff and let's be absolutely honest. There is a total reliance nationally on the underpaying of care workers. And of course, and there is an irony to this, guess what gender those care workers are? Of course they're going to be women, aren't they? Now your emancipation's going well, isn't it, folks? 78% of all care workers are women. A third of councils know that they pay less than the rate required to cover the cost of paying a care worker the minimum wage. 42% of non-residential care workers are still on 0-hour contracts. And we also know that they're not always paid for travel time or mileage. They have no guarantee, often, what their hours will be week in, week out. They do not have proper terms and conditions for things like sick pay, maternity pay, or indeed the odd holiday. And we all know, including the government, including councils, including the NHS, that frankly that is tantamount to exploiting the weakness of the care workforce. I admire greatly the honesty of 2 hospital trust bosses who told me that they had piloted running their own care services in-house. In fact, one was highly entertaining. And he said, Louise, you know, with a bit of arrogance, really, we thought, well, we can do this better than them. We run all of this. We'll run this. What's the problem? And he said they simply couldn't stack it up. They couldn't stack it up financially, as their staff would never accept those wages or indeed conditions, and they would never accept the liability for those people that they called patients. I love the fact that there are people working in the public sector that are prepared to tell the truth and be honest and face it. But we have to stand back from this and say there's something just a wee bit disingenuous here, isn't it? We all of us talk about being national living wage employers whilst we know this is going on. The average care worker salary is $23,500. That is 13.5% less than the absolute lowest rung in the civil service. I checked, I'm afraid, Thea. Nuffield, you start out at about 30 grand. Come on. No, that's too sensitive. Okay. Don't tell me that these people's jobs are tougher or more meaningful than somebody that looks after somebody in their home or looks after somebody in a care home. And again, to quote David Bean, why shouldn't a care assistant be able to aspire one day to become the chief nursing officer of their local hospital? And that's why today I'm pushing again to the work led by Stephen Kinnock and Ali McGovern from DHSE and MHCOG on workforce reform, why it's so vital. It doesn't need to wait for my review, and it needs to start to have the tough conversations to make the long overdue changes needed. Fragility, though, is also writ large when we look at providers and indeed commissioning. The word commissioning suggests, doesn't it, that there's a strong market where people have choice. Certainly on a human personal level, I didn't feel when they called me their adopted daughter, when they went into this terrible world of realising what happens to you when you fall over in a car park in Morrison's in Port Talbot, what the next 8 years of their life was going to look like. We had absolutely no choice about trying to barter people to come in to the home for 15 minutes twice a day, and we were self-payers at that point. On the one hand, you have small providers, some represented by good people in the room today, barely keeping the show on the road, a risk of toppling over at any given moment, either finding workarounds to make money work or, frankly, making their staff bear the brunt. I met one incredible care provider who allowed me to look through her books. The money she was getting from councils was barely enough to pay her staff, let alone the overhead costs. And there were minor overhead costs in comparison to probably any charity I've ever worked with. She was only staying afloat because she could recoup tiny nudges of money. For example, one local authority allowed her to keep the money when one of her clients went into hospital for 2 weeks. After 2 weeks, she could no longer keep the money. On the other hand, there are councils that feel held to ransom by powerful, sometimes private equity actually owned providers who can pull a contract or team up together and hold colleagues in local authorities over the barrel so they can extract the maximum profit from the public purse. One group of councils up in the northeast had to band together and threaten this group of private providers, would you believe, with cartel and competition legislation to stop them hiking their prices in unison. That is a sign of fragility. It's also apparent in the constant turnover of providers, a boom and bust cycle in frankly every area of the country. Boom and bust for the local authorities trying to organise, boom and bust for the human beings on the receiving end of their services. Each year, almost 2,000 home care agencies register with CQC and an equivalent number deregister. Nowadays, in fact, councils have specific teams to troubleshoot when providers collapse, Good work though this may be, and I'm grateful to them for doing it, it is a symptom of fragility of a market that doesn't work. And fair play to one former Director General of Social Care who admitted to us that he saw their only role to be stopping the system from falling over. I've talked about fragility. Now I want to talk about something a bit tougher. I want to talk about the separation, the deep and fundamental divide between the world of health and the world of social care. And can everybody take it as read? I, like the rest of the British public, brought up watching Angels on the telly. I love the NHS. It's one of the best things this country has ever built. But it's also why I want to speak frankly about why I think some things aren't working. Put simply, social care does not start and end with a social worker in a local authority doing an assessment, or one of us ending up in a care home. It starts when you first visit your GP with symptoms you can't explain. It starts when you enter A&E after a fall or sometimes after an accident. It doesn't stop being the problem of the health service when you are discharged from hospital. Social care isn't, I would suggest to colleagues, particularly in the hospital service, it is not simply a fast-track route to emptying out acute hospital beds. People who draw on social care are often people with health needs, with your long-term conditions, with frailty, with dementia, and sometimes with disabilities. A safe discharge is not the end of the NHS's role. I think as the NHS has evolved, it has withdrawn from the community, reducing the number of beds they offer other than for acute or specialised care, putting many more staff into hospitals whilst hollowing out the staff numbers in community and primary care provision. Day, I hope you don't mind me mentioning, but before we came in, you said the number of district nurses had dropped by 40% since 2019. All of this pushes the responsibility now onto councils. In my mind, and I can come back to this, it is my belief that we really have a national hospital service, not a national health service. And that may feel tough and may feel unfair, but that's what it looks like to me. And I'm under no illusions. I entirely understand the desire to keep people out of hospital. I understand and support the reduction in the number of long-term beds. I think some of that reflects extremely good changes in the way we treat and deal with people. People are no longer confined to some long-stay ward for their whole lives. People are able to live in the community, near friends and family. I also know that, contrary to popular opinion though, hospital is often not a safe place to be, so I get it. But hospitals are less safe, some would argue, for people who are frail, who are ageing, and who are elderly. Countless clinicians have said to me and given me very specific examples of a person coming into an A&E with, say, UTI or dehydration, lying on a hospital trolley for hours, sometimes days, waiting to be seen. To describe what this does to an older person, people use expressions like deconditioning. I'd never heard of this. They lie in bed because they don't walk. They sometimes catch an infection. They can sometimes be catheterized so they don't need to be helped to the toilet. And their carers, remember, are not allowed into the hospital to provide care. In other words, we come in from our own home and we exit to a care home. And I think that in itself should be pause for thought. How did we get to a point where hospital, this wonderful, wonderful thing that does so much good, keeps us so much alive for so much longer, is sometimes a route to the rapid decline for the frail and the elderly? Why are we treating everybody that comes into A&E in the same way, rather than having a different approach for people who are frail or indeed have dementia? And where we do, why is that the exception and not the norm? This divide between what is care and what is health doesn't exist to the public. It's our divide, based on our definitions, our categorisations that satisfy us and our institutions, not about the public. I don't think it's about what's best for the patient or the person. I know it's intended to be, but it isn't. And what often plays out then is a bun fight over who is responsible for what, time spent negotiating responsibilities, eligibilities, who foots the bill, with often families being the people that pick up the pieces. I visited one council who had spent 2.5 weeks arguing with a community health provider over who pays for incontinence pads in the care homes. 2.5 weeks of an assistant director's time. Look at budgets in continuing healthcare, money which provides free health and social care for people with complex health needs or end of life. So many councils tell us the decisions on who qualifies for this funding is, I quote, a major source of endless tension. And although assessments are often done jointly between the NHS and councils, more often than not, the final decision is made by the NHS. Again, notable exceptions to the rule, but they are the exceptions. Whilst I'm on it, I find it rather astonishing that some ICBs are paying private sector companies to find ways to cut how they pay out continuing healthcare budgets, and if these private companies are successful, they can take the profit. I'm not saying everybody in receipt of CHC should be in receipt. I don't make those assessments. It's nothing to do with me. I am wondering how on earth did we end up here? And whilst I'm on it, in case anybody from government is watching or listening, or works at the Treasury, or the Department of Health and Social Care, Sally's in the room, I know you are. I know exactly how much money is spent on CHC, and I will watch when it's under review whether that is sucked up into the world of acute hospitals or whether it stays central to its purpose. I'll be watching and I'll be saying if I'm unhappy with it. But it's not just the existence of the divide that causes the problem. Let's be completely frank here, because it's part of a reset and a re-beginning of social care. There's an extraordinary power differential between local councils and the NHS, which in my view, I'm sorry to say, the NHS wins every time. Time and time again, they triumph over local government. It's no wonder that people in social care tell us they feel like the poor relation, they feel forgotten and undervalued. There is no powerful, unified challenge to the primacy and the might of the NHS. And the public also don't exert any pressure for this to be done better. Sometimes I think through a lack of awareness. We just expect that health and social care will operate as one until, frankly, you have the misfortune to need it. And all of what I've talked about plays out, frankly, very clearly in relation to dementia and Alzheimer's disease. People in this room know, more than other people outside, that dementia and Alzheimer's are the leading cause of death in the UK. Dementia patients account for more than 1 in 10 bed days in acute care, this is NHS speak, and 1 in 10 delayed discharges for older adults. It's a big deal for the NHS. 50% of us fear dementia more than any other condition. And people living with dementia are not squeamish in telling me it's horrendous. Everybody will agree dementia is becoming more prevalent. People live longer, they have more diseases, they get dementia. But despite all of this predictable rise and the harm that it causes to families, I frankly, despite efforts, have not seen an equivalent response to this seismic challenge that is facing us. A response to fight it with the same brilliance, the same energy, the same drive, the same determination that we've seen in other areas like cancer. Why not? Is it because it's the elderly? Is it just too much of a taboo subject for us to front it out? Is it because that me, when I hit 67, I'm supposedly no longer economically active and therefore my voice doesn't count? I think it's for those reasons. Instead, dementia is seen as an inevitable part of ageing rather than caused by a set of conditions and diseases. People with dementia are seen as bed blocking rather than patients with neurological health conditions. New breakthrough drugs are seen as too expensive to deliver on the NHS for what they call the small benefits that they'll give. I get it. I've had to gatekeep money on behalf of the taxpayers for blinking years in jobs I've done. And I know the NHS can't afford every drug, but if I was diagnosed with Alzheimer's disease and told treatment would give me an extra 6 months to talk to my family and get my affairs in order before that disease note, took hold, I'm not sure I'd call that a small benefit. And if I was 70 and no longer economically active, there it doesn't figure in the right balance and stuff, I would still take that and take those 6 months any day. Any major breakthroughs in treatments are seen a way off and that there is no point in preparing the NHS to deliver them. And I find this incredibly odd from a health sector which is normally so reverent and driven about scientific and medical breakthroughs. Look at everything Chris was talking about on his slides this morning about vaccinations and changes. Overall, people with dementia, families bear the brunt, often left with little help. I met a man whose wife had really severe dementia, a grandmother, and needed huge amounts of care and support. They had consistently tried to get help, including the continuing healthcare grant, and didn't receive it. As soon as his wife gets seizures in said care home, a direct complication, the medics told them, of her dementia, guess what? The money kicked in. I guess that at that point it's classified in our system as medical and therefore it kicks in. Once the medication that controlled the seizures, the funding was then withdrawn. It's kind of hard to explain to the family, given that dementia is the real reason of why they are in that situation. It's hard to explain and it's inexplicable as to how the system can't operate more effectively than that. And I find it hard to explain myself. People are not told what to expect or what will happen once a dementia diagnosis has arrived. I had the honour, actually through Carers UK, of meeting a man in Newcastle who received a blue folder with 2 leaflets in when his 60-year-old wife was diagnosed with dementia. One on how to claim PIP and one on how to get his council tax reduced. He had money, they had money, they planned to retire early and do a bit of travelling. That never happened. He was left with 2 leaflets. He wanted to know what would happen next. Is there any treatment that she could have? What was going to happen? How would their lives change? What help could they get if they needed help? But he was left totally in the dark. Look, overall, it is not new, is it, that we are an ageing society. I smile when I say this because we have been ageing for ages. We have to get our heads around that. Frailty and getting old is an inevitable part of life. The National Health Service, in all its glory, before, during and after hospital, has to deal with a population that is older, frailer, and not deny that that is happening. But social care isn't also just for older people, it's for everyone. I just want to pause on a particular issue for a moment. Colleagues that have worked with me before know that sometimes when I look at an issue of a problem, I try to look about what's happening for those most in need, and it can often shine a light on bigger and systemic issues. So for this, I've looked at some of the more severe conditions that affect people. People who the public would assume get a Rolls-Royce service. Motor neurone disease, or MND, as all of you know, is one of the most severe and fast-moving conditions that we can face. It's thankfully rare. It affects around 5,000 people in the UK at any one time. But its progress is as predictable as it is brutal. The median survival is 22 months from diagnosis. But despite this, unlike, interestingly, the benefits system, our health and social care systems don't reflect this. People are still put through multiple assessments, multiple means tests. Care packages are adjusted only after someone predictably deteriorates. There are long waiting lists. It made us look at things like major home adaptations, which for everybody, there's an average wait of 375 days. An average wait for a home adaptation for somebody with motor neurone disease of over 375 days. Some of those people don't make it that long. For a person with less than 2 years to live, I defy anyone to say that this isn't unacceptable. And I am not blaming the people who run those assessments and operate that system. Many of them do it with such compassion and try and break the rules, cut things, fast-track things, left, right and centre. There are some local areas that have introduced faster routes for some grants, but again, these are the exceptions. They are not the standard. In practice, it means that help can come too late, or not at all, or that we end up with people crowdfunding through desperation. And I have no doubt that as a country, we would expect a diagnosis such of that condition to trigger the best of treatment and the best of care for those people. I know that we cannot fix the problems of everything without looking at the entirety of the system. And I committed at the beginning of this, and I recommit today, that I will continue to look at all of these issues through the lens of the adult and their family who need social care. But there is also a challenge here to the public. We need an honest conversation with the public directly about what they want a national health service and a national care service to look like, not just amongst ourselves in rooms like this or within what we would call the sector. I think we need a mandate from the people who pay for health and social care through their taxes and national insurance, but might not even know what it is. And it needs to be about more than just whether people should have to sell their home or not. It's really tough questions like who should be able to draw from the system? Where do we draw the line? What should we expect from families? What lies with the state? What contributions should be made, when and how? We now need to work with the public to create a system fit for the nation that we are today. Soon we will publish our first report on the issues I've highlighted today and more, but on 3 issues that I've talked about today, I have written to Wes, the Secretary of State for Health and Social Care, asking him urgently to do the following: to set up a new national safeguarding board, ending the abdication responsibility for protecting people who are vulnerable and at risk of abuse. And I would like that safeguarding board to be on a proper legal statutory footing as it is for children. I would like him to give immediate backing to the scale up of investment in dementia trials. I would like us to introduce a new full-time dementia czar, and I would like us to drive faster progress on the modern service framework for frailty and for dementia. And finally, to create a new fast-track passport for people diagnosed with MND, meaning people living with this diagnosis and their families will not have to wait for healthcare, carer support, and indeed housing adaptations. These are small, straightforward, simple asks, and I will look carefully to see whether they are agreed to and whether they are delivered. I don't delude myself. These are modern changes, but all of those point to bigger structural challenges ahead. The story of social care so far is not one of neglect or indeed bad faith. We've gained stronger rights, better recognition, important legal protections, But I would argue reform has remained underpowered. Commissions without delivery, rights without funding, national problems pushed onto local councils, poor paying conditions for the very workforce carrying it. A system which means some needs are barely met at all, others are met late, and often in piecemeal and random ways. Nearly 80 years on from Beveridge, thankfully, in many ways, our country is very different. But we now face a fundamental challenge, a sixth giant, which barely existed and was needed in 1948 when Beveridge wrote his report. How can we support and care for the population that we have today and in the future? This giant, this sixth giant, is not actually born of failure. As I said at the beginning, it is born of success, longer lives, survival into old age, medical breakthroughs and progress, greater equality for women and for people who are disabled. It shouldn't be beyond us to think, should it? How would Beveridge, if he was here today, assess this vastly changed nation? Shouldn't matter if somebody's a social worker, a doctor, a district nurse, a carer, or a hospital consultant. The challenge for all of us is to get this right, to get it right now, and to do it collectively. How do we ensure that care and support is available for those who need it in a fair, in a dignified way that reflects, frankly, the nation and the values that I think we hold dear? It is a moment of reckoning. It should be a moment of renewal. Thank you very much. No idea what time it is.
That was great.
Do you have any idea what time it is?
Sorry.
No idea what time it is. Lost
Fine.
my sense of time there.
Don't worry about it.
Was that 2 hours?
Yeah, it was. 2.5 hours.
Got more to say?
I really enjoyed it, actually. It was really good and thoughtful. And I know that this audience has a lot of questions. So I'm going to allow myself maybe one only, because it would be rude not to let this audience to speak. And I was really struck by you talking, which is something I know very well, that the public do not think health and social care are different. We know from recent polling that at least 30% of the public think that they are exactly the same. That the most vulnerable points of their life is often the point where they're suddenly told, oh, you may have to pay for that. And the ignominy of the sort of thing you described, which is the argument as to who's going to pay for incontinence pads, which is distressing for everybody involved, but obviously most importantly, the family. And as I listened to you, I thought, do you think you're going to explore the pros and cons of bringing them together? Or are you going to explore the pros and cons of taking charging out? You're going to look at things like continuing care, which I think is actually a completely broken system. I don't know if I'm leading you too far, and just say shut up. I'm quite sure you will.
No.
It just thought, from what you were saying, I thought, you're going to go there.
Yeah, I think we should go anywhere that makes the sixth giant of what is needed in terms of care and support for the population I've talked about, which is the population we have in this country in 2026, and that population is going to continue with those changes. So if you don't look at all of these things, then you're not able to brigade something that makes more sense. I mean, it's not just, the thing about charging I find quite interesting in that if people know where they stand with it, but you're being charged for something that is utter shite. And that's the problem. There are some that are brilliant, absolutely brilliant, but when actually you're feeling that you're paying for a 50-minute interview and then it's down to a minute interview, the minute by hour, the sort of minute contracts, it's like we've lost our minds. How do we create something that meant that I am having to work, I'm ringing round everybody trying to think of somebody to come to see Viv and Margaret for 15 minutes a day. I remember looking at when the care home situation came, I literally looked at the sheet of A4 on a Friday and thought, you know, I'll have to do a ring round myself. It's sort of, you're left on your own. It's not just the money, it's the fact that we don't know what our responsibilities are as human beings in that. And I think it's so opaque and unclear. And of course, that's why people want them to stay in hospital.
It is.
I mean, you know, families are desperate to keep their loved ones in hospital, because the irony is they think that's a better place for them to be, which most of you tell me it isn't. But, you know, I think we've got to attack and look at some of these issues and be open to change. And I know that's hard. And I don't think, Thea, just to get, so I'm now slightly hyped because I've done a speech, and I haven't done a speech in a year, and as you can see, the adrenaline is pumping, and one of my team needs to shoot me with something that calms me down at some point, and I know it's too early to drink, but...
it's fine, it's fine.
You all laughed, so I'm feeling slightly better than I was at the beginning, but I just think nothing should be off the table.
And that's really what I'm saying, and I found that from what you were saying. You went through the list of all the reviews that people in this room know about, and you know there was a big critique right at the beginning when you started the commission, which was like, oh, we know it, we've seen all these commissions, why are we just not getting on with it? I get the feeling from what you've been doing for a year, and do correct me if I'm wrong, that actually you feel we don't know it all. It hasn't all been laid out well enough. It hasn't been articulated maybe at a political level at the complexity of how broken, how much problem or challenge there is, as well as, of course, all the great stuff, but the systemic problems. That when you looked at all these reviews, do you now think, well, there were gaps, there were things that weren't there?
I think that so individually you can take, I don't know, charging reform, you can take different deal for the elderly, you can take, how do we, you know, the dementia tax by Theresa May. Some of the 22 were very thorough. The problem is that we haven't actually stepped back and looked at what the evidence is that is driving what we need a social care system to be and to look like. And it isn't just about adult social care, which is why I deliberately today have pushed very hard on the fact that I think the National Health Service has a responsibility around social care. Last time I checked, most of us start with our GP when something isn't okay and say it's a broken leg that we're having fixed. It's not necessarily a social work assessment that I need. It might be a physio or an occupational therapist. You know, GPs used to visit people at home. It's sort of, I'm not having a go at GPs, incidentally. As I said in the speech, you can see the changes in financial decisions that were made, and then I sat through the session where people were feeling very hard-pressed as managers and chief execs in the NHS, another, you know, your session that you ran. So I understand some of the tensions around it, but I think that we have to we have to find a way to step back and look at what the evidence is. We have to understand that we're an ageing population. We have to understand what that means. You can't just, you know, shops used to be everybody going in person. Now shops are halved with people going in person, and people have their stuff sent by Amazon to the home. So shops have changed. So we have to change. Yeah. And I don't think we've changed sufficiently. And I think because people, particularly in local authorities and the charitable sector and actually some private providers, are into this hand-to-mouth existence of just keeping their head above the water, it's quite hard for them to step back and think, what would we do?
And you've talked for a sort of a reckoning, which I think is something that people will definitely take away from.
And we need to talk to the public. So the thing I think is quite interesting about the political backwards and forwards on it is that actually what sometimes you need to do, and I don't just mean polling. You know, I was entertained by a colleague in government recently that said, Louise, the thing is, you know, of course the public will say, I'll pay more for the NHS, but they mean a penny a week. So in this great 550% of the public, 98% of the public would agree with paying more to the NHS. When you ask them how much, they mean a penny a week. Well, that won't keep most people in this room happy with their salary packages. I mean, you know, come on, sorry, it's a bit rude, but I'm paid well as well, don't worry. But, you know, it's like not going to keep the show on the road of the NHS a penny a week. So I think you've got to calibrate those conversations directly with the public and not just run polling that tells you what you want to hear.
No, and we could talk about the public, but I promised I'd only ask one, and I asked two, so I should go to the audience, and they're going to be, oh, you see, I knew. It's really hard for me to see and to make judgments of which way I'm going to go. I'll go this way, across the room. She's from Carers UK. I think she's Carers UK. Yeah, she's Carers UK.
Yeah. Thank you. I'm Emily Holtzhausen from Carers UK, and just thank you so much for setting it out. This is what families sort of talk about all the time, which I know you've seen. It's you know, having been through all of those reviews myself and part of them on the receiving end, you know, really wish you great speed. We'll support you through that as well. My question is about hidden costs, and great to hear that nothing's off the table, and whether you think there's an important narrative to also tell around the impact on families, particularly women juggling work and care, and some of the bigger impacts that have later in their life, being an underpensioned group. And of course there are many disabled people who would love to work with the ability of more care services that we're losing from the labour market.
Okay.
And how important you see that as in the future in telling the story.
Great. I'm going to take a couple of questions. Oh, golly. Let's just go across here, and then I'll go backwards. I know I'm never going to get to it.
Caraher, the Chief Policy and Research Officer at Alzheimer's Society. So first of all, Louise, thank you for deeply listening with care and compassion to the people affected by dementia. I know you spent time with our Singing for the Brain service at the Alexandra Palace. But I wanted to pick up Thea's point about integration, because the challenge that we have with dementia is that it does start in the health system. It is a disease. These are pathologies of the brain. But the service that we have is a diagnose to discharge model. So once you get into a memory service, you're discharged, and then we have people navigating this complexity and ending up in crisis, as you described, probably more passionately than I could, actually. So there's something for us about integration. So how do you see that we can properly integrate around the needs of the individuals and their families? And when we think about dementia being the UK's biggest killer, the majority of people in receipt of social care, is there a route to take dementia as the kind of flag waver of getting the system right, of working together?
Okay. I know I'm not going to be able to get to everybody, but I think to take more than two questions, can I take? Shall I take?
No,
let's do I'll take one more. Jane, go on.
Thank you. I just want to add my thanks, Louise. Thank you very much for listening. I want to ask about political courage. If you're Wes Streeting, he's quite fond of saying elections are where social care goes to die. And that's a reality for people like him, because other people that have tried to bring about change haven't succeeded. And the polls show the public care about cost of living affordability, NHS, which they think is social care as well, and immigration. Is there a way that we can support the politicians to bring social care as part of that NHS debate, which they know the public likes? And how do we get them to develop the courage to do what Beveridge and Co did?
Great. So we've got three there. You can take many. We've got political courage, we've got integration and how we're going to do it, and hidden costs.
Okay, firstly, Emily, I think you're completely right about hidden costs, and I think it's something that we're definitely going to look at. We're going to do some financial modelling, and I think that partly, as ever, you have a sort of treasury head, and I mean that respectfully, that will think, how does that affect the economy, and etc. And I went there slightly in what I was saying, which is, in a way, because when one hits a certain age, you're seen as no longer economically active. I've been wondering about whether that's one of the reasons why this isn't taken as seriously. Plus, of course, you know, joking aside, we all don't particularly want to get old, and we certainly don't want to get frail, and I definitely don't want to have dementia. So I think it's a combination of a kind of cultural sticking your head in the sand, as well as the same time of actually that there are some drivers that people aren't good enough about how you do financial modelling to look at hidden costs. And so I think that then gets you to the word carer. And I think that what the growth of both yourself and others in the carers lobby have done really well is start to show the impact on families and taking them out of the working environment and the cost that there is, not just to them, but to the families. So yeah, we're interested in all of that. Fiona, on the Alzheimer's front, first of all, thank you so much to you and to colleagues in the Alzheimer's sector for the support that we've had. It's partly why, and it feels a bit techie, I've pushed very much this modern service framework because apart from the fact that some colleagues in ADAS didn't know it even existed, and I'm partly pushing Wes and colleagues in the Department of Health to look at how the modern service framework that is in the NHS plan should be a framework developed in partnership between colleagues in local authorities, colleagues in organisations like yours, and colleagues in the NHS. And there's no reason why that can't happen. And if we could get a modern service framework that doesn't have to wait for me to write anything or do anything, because it is in the plan, people know what they should be doing and we should drive on with it, then essentially I think that it would be, as you put it, a very good way of us showing what integration could look like. And I think that having met now so many people that are people that are elderly or older, and couples where one has Alzheimer's and one doesn't have Alzheimer's, I have sometimes worried about the person that doesn't have Alzheimer's as much as about the person that does in those families, and the stress and the pressure we're putting on them, and that they don't feel heard either. And they wouldn't, as Emily knows, they wouldn't all describe themselves as carers, like the chap that I met in Newcastle. And then finally, it's a really fair point about cross-party. And I suppose, you know, the thing is that nobody in this room can stop politics, right? It is what it is, and it's democracy, and I love democracy. I'd rather have that than some tyrannical regime that does terrible things. But what comes with that is political cycles. So the reason I pushed to do this commission and to push to do something quite significant with it is so that we're able to essentially try and show that the evidence takes any government of any persuasion to a certain point. And the reason that we're turning our attention now to a national conversation with the public is so that we're able to brigade the evidence of what we think the public really do want and how, which isn't as straightforward as just telling them that they need to pay more tax, incidentally, just to be absolutely clear about that. I think that will really help broaden out from this being a sector battle to being a public battle. And I think that that might be the technique that might help us. Excellent.
I'm going to take another round of questions, and I'm trying so hard to be fair at the moment. At the front here, and first question, and there, Laura, and
Sandy.
Okay, let's go first. Let's try. She's a chair in the Ask for Health. She's a chair of the Health Trust. Fantastic.
Thank you. I mean, there's so much richness there, and I think just a huge thank you for the effort and thought you're putting into this. My name's Mary Elford. I'm chair of Homerton Healthcare.
Oh.
But actually...
Very near me. Right, excellent. I'll see you later. Excellent. Or any London Health Trust near anywhere in Finsbury Park. Please see me after.
My question is coming from me as a mum. I have two daughters, one of whom has learning and physical disabilities and has 24-hour support. And I think it's hard to understate the extent of the workforce crisis and the degree to which that is what's keeping mums like me and fellow mums awake at night. The reliance, particularly in central London now, on agency staff, on people who've come here, very, very high standards of care, but it's not a reliable workforce, mainly agency workers who are tied into sponsorship from their agencies. I think under the guidelines that are being proposed, that route to staff will not be open to the care providers. So my first question is, can we? What are your plans for actually negotiating what's going to be a really tough one, because it's kind of the interface of money and immigration. So we're interested to know how you're going to take forward that.
I'm going to stop you on one question.
Sorry, just one plea. Just also, I always feel like social care is talked about through such a negative lens, and anything can be done to actually kind of convey the excitement of the work and the joy in the work in looking after a young woman in her 20s to live her very best life. So.
Yeah, absolutely, and thank you for that. And we had two questions over here, and I do absolutely know that I've been rubbish at not going further back in the room, for which I can only apologise.
Hi.
Been told
Hi, Louise. Thank you for being here today. I think I was struck by two of the points you made. I think one was about power and power imbalance, and also the dehumanising experience too many people have when interacting with the system. I can see, and taking on the previous point as well, that obviously the reason the Commission is in existence is because too many people are having bad experiences, and you're learning from those experiences. But are you also being able to see some of the positive experiences people are having in social care, and what good looks like as a way to kind of draw and amplify those? And my second point would be, as someone part of the Social Care Future movement, we're eager to get involved, to assist, to find more of those stories about what good looks like, and also connect you with people who draw and support directly to kind of give a bit of guidance and support where required and needed, and that offer is open. So thank you.
Thank you.
Brilliant. So we've got two questions. I said to take a third, and I think then I'm being told I'm going to have to wrap the session up. So this gentleman here, you are around this evening, though.
No, thanks very much, Baroness Casey. My name's Darren Hughes. I work for the Welsh NHS Confederation.
Excellent.
And you might have already guessed where this question is going. You talked about, I'm first of all massively assured by the passion and honesty I've heard from you today. I regularly speak with the Social Care Minister in Wales, the Health Minister in Wales, ADSS Cymru, Welsh Local Government Association, and you alluded to the fact that multiple governments have failed to deal with this as an issue in the political cycle. Can I say governments in the devolved administrations as well, and please would you consider looking at what's going on? I know you had a visit planned to Wales, but looking what's going on in Northern Ireland, Scotland. We've got sticking plasters going on. The way the money flows is very dependent on decisions in Westminster. You've got Stephen Kinnock, a Welsh MP, overseeing this in quite a weird way. But I'd like to invite you to come to Wales to look at this and consider making recommendations for the whole of the UK, as it's a UK government commission.
Yeah, on the elderly side, or the getting older side, my lived experience is Port Talbot, Neath Port Talbot, and then Bridgend. So I'm very, very familiar with South Wales. I'll probably pull off a Nessa-style accent if I needed to. I wasn't in a posh environment like this. We're really keen to... We've looked at some of the issues in Wales, Northern Ireland and Scotland, and we're very keen to learn from what can happen in those areas, and I'll take you up on that, Darren. Thank you. Just whilst I'm answering the other questions, I am interested in anybody who's like NHS Central and whether it jarred when I said I think it's the National Hospital Service. I did see some people nodding, but I just wondered if anybody had a question or a concern about that. I'd really like to know that. So just whilst I answer the other two, Andy, we've met and you've helped on a number of occasions in the last 12 months, for which myself and my team are very, very keen. I think to continue and to have a structured relationship, particularly as we go into the big national conversation. I think the thing that is very hard for somebody like me is that, and you alluded to working in homelessness, is I could give you I could stand up today and give you countless and countless and counsel example the same way it sounds like it's Mary, isn't it? The carers for your daughter. Give love, give care, give compassion, allow people to live fully independent and equal lives, which is the important thing. All of this is actually about equality, particularly for working age human beings. I suppose that when I come to roles like this, I know what can work, I bank it, and I look for what isn't working, and I try and work out, or forgive me, there are colleagues here after I've gone today, we try and work out kind of what isn't okay. And I suppose the risk of being apple pie and motherhood is just, I think, one of the most enormous gifts of humanity is the way we show love, actually, most of the time, is a cup of tea, or whether somebody's warm, whether, it's a physical thing. It's often a way, I used to go into very, very difficult families, and the thing you do is you check if there's a bit of food, and you help them cook. And often we get caught up in the world of assessments and of assessments and more assessments, and we start talking about how somebody got capacity to be a mum, as opposed to, is she all right, and why isn't she coping? And our language dehumanises the most extraordinary gift that any of us have as human beings. And God, I hope I keep this in me to the last day I draw breath, which is, I hope that we can all convey love for each other through the way that we care and we show compassion. And when we don't get that right is where I think, the bad stuff starts. And so I take it as read that most of us in humanity want to be that way with each other. I think some people find physical, personal care harder than others. I think that's partly because there's value attached to that, when I think it's the greatest gift that you can do is to look after somebody physically, particularly if it enables them to be equal. And I think there's an awful lot of stigma attached to the world of care, which interestingly isn't attached to the world of the NHS. And I just feel these are the things that we need to use this reckoning and this renewal moment to switch out. So I think it's fair of you to say I should seek more of the positive, and I will, but I just want to be straight and honest with you as well as with everybody else in the room. I'm a troubleshooter and a fixer, and so I smell out and look where the problems are. I ask the difficult questions and I see if we can do something better. But I know sometimes that isn't always easy and hard to hear. There was something about unrealistic. That was Mary. I've got that one. Andy, dehumanising. Darren, Wales. There we go.
Right. Can we say thank you?